so that we can share the link with the rest of the group that are out there.
Yes, Shem, are you ready? You are ready? No. Yes, you can go online. You can go live now. Yeah, you can tell your friends to get online. We are going to get live right now, right now. Yes. Yes, Dr. Maura.
Let's share the link.
I did share the link kwa JKURSA and some other groups. The one that I've shared, nearly shared 3:05 p.m. Yes, that one that is the one that I'm going to be using.
So they're going to use the one that we had.
No, the one that I've shared. The one that I've shared right now. 3:05. Yes, now you can circulate the links so that we can start our CME this semester.
Okay, once again, please, welcome to this CME. And the theme for today's CME is new trends in imaging. And as I said earlier, we're going to have 4 presenters. Without wasting so much time, I am going to invite Kadra Abdul Kadir to come and make her presentation. Welcome, Kadra.
Good afternoon, everybody. Good afternoon, those who are live streaming. My name is Kadra Abdul Kadir. I'm a fourth year student in JKUAT, and I'm privileged to be the chairperson of JKURSA. Thank you once again, and welcome. So I'm going to present on types of magnets and the applications in MRI. We have categories of magnetic materials. There are majorly 4. And they include the diamagnetic, paramagnetic, superparamagnetic, and ferromagnetic. For the diamagnetic materials, these materials have paired electrons. They show small magnetic moments that oppose the applied magnetic field, and they are not attracted to magnets. So therefore, they are categorized as, or they have low magnetic susceptibility according to MRI. And they also, some of these materials include carbon, we have copper, we have materials, we have, water, mercury, lead, gold, and wood. On our second magnetic materials, we have paramagnetic materials. These have unpaired electrons. They have small magnetic moments, and they align with the applied magnetic field, thus adding up. And and they are also attracted to magnetic materials. So therefore, they are categorized as they have a low magnetic susceptibility, or they have low positive susceptibility. Such materials include the tungsten, aluminium, sodium, and gadolinium chelates. On our third material, which is superparamagnetic, these materials have intermediate positive susceptibility, and they are like greater than paramagnetic but lesser than ferromagnetic. We'll look into ferromagnetics later. Examples of these materials include the iron oxide, which is also a contrast agent. To our last magnetic material, we have ferromagnetic, I mentioned earlier. So these materials have a half-filled electron shields. They have a strong attraction and align very well with magnets, so therefore they are categorized as they are having a high positive magnetic susceptibility. And they are very dangerous projectiles. Such ferromagnetic materials include iron, steel, nickel, and gadolinium in its native form. My second presentation is about magnets generally. So magnets are majorly categorized into two. We have the permanent magnets and we have the electromagnetic magnets. For the electromagnetic magnets, they're also categorized into two. We have the superconductive and the resistive. So for the permanent magnets, these magnets are permanently magnetized and do not depend on an external source to maintain their magnetic field. And they are majorly used in MRI scanners, but their Tesla is very low, and they can go to as low as 1 Tesla, and they are less costly. And they were used in early times, but nowadays they have gone out of market, and we have advanced to better magnetic materials. So they do not need cryogen for cooling. We'll talk about cryogen in the next slide. And they have a very small fringe field, and they are very heavy. They range from 15,000 to 30,000 kgs, and they're mostly installed in ground floor. For the electromagnetic ones, so these are magnets which use electromagnetic current to generate magnetic field. I believe every radiographer here did physics, and probably in our Form 3, we learned about electromagnetic materials, and we came across such a statement. So they are produced by placing a metal core, usually in an iron alloy, inside a coil of wire carrying an electric current. The electric current thus produces a magnetic field around that equipment or that object. So for the electromagnets, they include, like I mentioned earlier, we have the resistive electromagnetic materials and we have superconductive electromagnetic materials. So for the resistive, they can be switched on and off, and they have a very low Tesla, as I mentioned. They can go to as low as 0.3 Teslas to 0.6 Teslas. For the superconductive magnets, they have higher Teslas. Majority of these are used in the hospitals. You'll come across in your clinical rotation for junior, which are the first years. And they operate on very low temperatures of negative to 70 degrees Celsius, and they need cryogen for cooling, which is liquid nitrogen or helium. One of the disadvantages of our superconductive magnets it's that they are very expensive. Thank you.
Thank you, Kadra, for that presentation. You've set the pace for the rest of the speakers. And now it's my pleasure to invite the next speaker, who is Dennis. Of course, Dennis was or is an alumni of Jomo Kenyatta University sometimes back. He is one of the graduates or graduates radiographer that is making JKUAT proud out there by the things that he's doing. We are actually very proud of Dennis because I'm sure he's going to give us a brief of what he's doing and we'll get to understand that he's done great things. So Dennis, you're welcome.
Thank you very much. So by name, my name is Dennis Kibet. I'm the clinical education specialist for GE Healthcare representing MRI. So my role basically involves delivering training and continuous customers and also CMEs. So the topic for today is we are going to cover the innovation technology with focus in magnetic resonance imaging. So the emphasis for today is that we are working on technologies that directly influence. So those who have been able to rotate in the clinical practice, can you be able to mention any technologies you have come across that has an impact on the patient? So those who are here, you can just raise your hand. Just mention any technology that helps us to serve our patients better, especially while doing the MR scans. Online, they can just leave a chat. Yes.
We have advanced to MRI with much higher Tesla, and they have a very high resolution, which is very good and very easy to diagnose patients with different indications.
Okay, I second that. So basically, field strength, the more the signal we can get, the better image quality we can be able to see from the MR. Any other new innovation that you have come across? There is no wrong answer. Yes. You just have to explain how contrast enhances.
We were thinking the same. How does contrast, how is contrast a new innovation? Back then we used to have contrast that used to be, for lack of better words, bad to the patient. Now GE have VCPEC, which is good to the patient.
Any other? Yes.
Another improvement that has been noted in the MRI modality is we have MRI magnets that don't require helium for them to operate, hence saving on costs.
Okay, so another improvement comes like nowadays there is functional MRI, the fMRI, that doesn't only examine the anatomy of organs, also examines the functionality. Like for example, with the brain, you can assess the ability or efficiency of the brain to.
Yeah, I think I'll just add something, Dennis, on the question of the contrast is an innovation. What was the question? Whether there's right?
any innovation that you have come across in the field that
Yes.
help us serve our patients better.
Yeah, correct. So contrast, if there's something that is subjected to ongoing and continuous R&D, research and development, is contrast, because as you know, it is a pharmaceutical agent that you inject directly into the patient. So when you go to a CT or an MR room, I think contrast is the only item that you use that you have to get it into the body of the patient. Yeah. So because of this, it is one of the products in radiology that is subjected to very rigorous pharmacovigilance. In pharmacology, we have something called pharmacovigilance, and I know you're going to encounter it maybe in one of the units. So pharmacovigilance is, as it is, becoming vigilant on that pharmacological component that you are using. And vigilance is in terms of how you are using it. Is it, you are using it the right way? Are you using it for the right indication? And how it reacts to the patient. You need to be vigilant enough to know how the patients, your patients, are responding to the various doses of contrast media that you are giving to them. You monitor. After, of course, doing the right protocol before injection, you need to identify the patient profile and you give the right contrast. In CT, for example, as Camilla has said, there is an isosmolar contrast that you give to those at-risk patients. At-risk patients are those that are kidney function is compromised, plus other categories of patients that benefit from that. And then post-administration, you need to monitor your patients up to 72 hours, to just see whether they're developing any reactions that would be linked to contrast media. On the side of us, the industry, and specifically for MR, every company is trying to move away from gadolinium because all contrast media for MRI are manufactured by a base component known as gadolinium. And as GE, we are trying to move away from that because gadolinium, it has been stable over the years, but the only challenge we are getting, gadolinium has some affinity towards towards the brain unnecessarily. Something called the brain deposition. And you guys, I like you because you're scientists. I know you're taking notes and you're going to try to refer and Google here and there. There's something called gadolinium deposit, which affects contrast media for MRI. And therefore, because of this, we don't have any established side effects for this, but so you can see all these innovations are towards the patient safety. So what drives innovations in healthcare is patient safety, and that's why for contrast media we have all this research and development going towards that. So I think Dennis have tried to answer that.
Absolutely. So I am sure each and every one of us will be able to mention one or two that they have come across. So I'll start by defining the term innovation. So basically innovation is derived from a Latin word, innovare, which means, so innovation is a continuous process in which a product or a service and brought up to date by new processes, introducing new techniques, or establishing successful ideas to create a new value. So whatever we have now in the next 5 years may be improved to become something better. And what was being done 10 years ago is different from what is done today. So there's a gradual improvement and we have to be up to date through those processes. I'll just do a quick definition of the MRI, which is a modality that uses ionizing radiation to generate images. We know that in MRI we use the radio frequencies transmitted by radio frequency coil, sent to the patient. We use the gradient coil to localize, and then we generate our image. So over the past years, the role of MR has been expanding, not only in the diagnosis, but also in the follow-up of conditions. So when a patient is diagnosed with a tumor and they go to treatment, back again to MRI to recheck on the progress. So it's an evolution that is ongoing now in this world, MRI has not been left behind. So, what are the regions that we focus on in MRI as far as innovation is involved? So, our focus is to optimize on the image quality. Our focus is also in improving patient's comfort and also the scanning speed, not only to scan faster, but to scan faster and produce images that are of good diagnostic quality. And this is made possible through not only hardware, but also software improvements that is continuous. So I just made a short list of 8 of the innovations, regions of innovation. This is not the complete list. For the sake of time, I'll just go through this, but the list is endless. As we have mentioned right now, some of what was mentioned are not in this list, but are still part of innovations. So I segregated them into some groups. So the first group will involve the RF coils. So we'll go through the innovations that are recent, which are in the RF technology. The second one is on increasing the scanning speed. Fast imaging techniques, we'll go through those. The third one is on artificial intelligence. Right now, it's being integrated to everything. The fourth one is on synthetic MRI, whereby just an example is like killing 2 birds with 1 stone. You can be able to acquire one image and then post-process multiple other image contrasts. Number 5 is on motion correction, which is a big challenge in MR imaging. So when the patient moves, it affects the image quality. Movement can either be voluntary or involuntary. So voluntary is the one that the patient is moving. Involuntary, when the patient has no control, or some structures that you are imaging that are dynamic, like the heart. You cannot stop the heart to image it. You have to image as it beats. If you stop, you kill the patient. Okay. Another one is on bone imaging. Bone imaging was normally reserved for ionizing radiation, whereby we use either CT scan or X-ray to image the bones. But we have recent technologies that we can be able to image bone in MRI. And then number 7 is on vessel wall imaging, which was exclusively mainly done in a cath lab or CT angiographies. Right now, we have techniques that you can be able to assess the vessels wall. And then number 8 is on arterial spin labeling, which is a non-contrast imaging technique to assess blood flow to the brain. These are type of perfusion. So one disclaimer that I'll give in this presentation is that the examples that I'll be using are from GE Healthcare, and some of them may be universal. They can be in every vendor, and some of them can only be found exclusively in the GE systems alone. So, but the list here is a general description. So I'll start on the RF technology. So RF coils are the critical components of the MRI. They are basically like the eyes of the MRIs, and they help us to broadcast and receive signal. So we use the RF coils to send the signal to the patient, and we use the RF coils to receive the signal from the patient before we can localize it. There are 2 common types of the RF coils. So we have the volume coils. These are normally cylindrical in shape, and like the head coil, like the body coil, like the knee coil, whereby the structure that is being imaged is put inside the coil. And then we have the surface coils. These are normally like flat coils, whereby you put on the surface of the patient, like the anterior coil. The coils can be able to perform in 2 ways. They can either be transmit, receive, or they can only be receive. So transmit, receive coils are the coils that are able to send the RF and then receive. But some other coils are receive only, whereby the transmit RF comes from the body coil, which is embedded into the bore of the MR. So what are the recent technologies that innovations that have occurred in the coil technology. So we have the phase array technology, whereby we use multiple small coils that are overlapped so that they can improve on the overall signal. So these are arrangements of small coils that work together to amplify on the signal. And then another area of innovation was on the coil design, whereby we made a transition from the traditional coils to these new other coils known as the air coils. If you've gone to any MR site, if you see the coils, they are normally hard and rigid. But with this new coil technology known as the air coil technology, the coil is soft, it's flexible, it's almost like a blanket in which you can just put on top of the patient. They are called the air coils. So basically the analogy is that the air is able to go freely around any structure. That is how the air coils mimics. So the emphasis is on the patient comfort, whereby they are light. If you put on the patient, they are not heavy. And also even for the MR radiographer, moving the coil from the scanner and putting them at the storages, they are very light to move around. And also they have a consistent and high image quality because of the high number of channels. These are up to 30 channels. And they offer unrestricted coil positioning. So you can be able to scan in any region. You can put it on the abdomen, you can scan it on the shoulder, extremities, any region. So they are quite versatile. The second is on fast imaging techniques. So as I said, the focus is not to scan faster. The focus is to scan faster and also maintain a good image quality, because yes, we can be able to accelerate and scan with the shortest time, but we may lose on the diagnostic quality of the images. So scanning faster, first of all, will reduce the scan time, and also this will reduce on the motion related artifacts. So like when you are scanning the heart is moving, so we have to scan faster. And as you know, MRI has a low temporal resolution. Yes, it has a high spatial and contrast resolution, but on the temporal resolution, whereby we are scanning a moving structure, MRI is limited. And most of the technologies now are trying to work around that to make MR scan faster. So these will be used also in 3D imaging, in sign imaging, like in cardiac imaging, and in flow imaging, where we are imaging the blood flow. The techniques that are being used now to accelerate imaging include parallel imaging. So this involves the reduction of the phase encoding steps by selectively undersampling. So let's say you are scanning the head and the coil elements are around the head. So if you have a receiver element in front of the head, we know that it will receive a low signal that is coming from the posterior part of the head, but will have a higher signal from the anterior part of the head. Same to the coil that will be on my right. It will receive higher signal because it is closer to that region of interest. So what we do in parallel imaging is that we can undersample now in that specific region. So the coil that is anterior or to the front side of my head will sample more signal on that region. And then since we know that the positioning of the coil, we can now be able to combine the images, and this will improve on the image quality, and also we are able to scan faster. The other one is on multi-slice imaging, whereby we use multiplex or summation, a combination of multiple RF pulses to excite multiple slices. And then these slices are now analyzed or unfolded to correspond to their specific slices. So it's like we are imaging 2 or more slices at once, instead of sending one RF slice select and then fill one line of K space and then repeat again for the next slide and next slice. So we can be able now to send a summation of 2 RFs and then read the image and then analyze it to reconstruct to produce multiple slices at once. Feel free to interrupt in case there's a point you don't understand. I can repeat. Okay. Another one is on compressed sensing or hypersense. Is a type of advanced imaging, which is a type of parallel imaging. It also relies on undersampling, but this will use a iterative reconstruction, almost similar to that used in CT scan, to reconstruct the images without any loss on the image quality. The next one is on artificial intelligence. So before I can proceed, I wanted to first define these three terms. So the first one was on artificial intelligence, which is a field on computer science focused on developing intelligent machines to perform complex tasks that will typically require human intelligence. They are designed to learn from data and can use predefined rules. The next was on machine learning, which is a subset of artificial intelligence that uses algorithms to learn patterns from data. So you see, machine learning will learn patterns from the data and requires a huge amount of data. Deep learning is a subset also of machine learning that employs artificial neural networks to perform complex tasks. So in deep learning, now the machine is trying to reason like a human being. So how do we use AI in MR? We use it to simplify workflow. Workflow in MR is the processes that the patient will go through. So from positioning the patient, centering the patient into the bore, selecting your protocols, planning, post-processing, and things like that. That is the workflow that will involve in the MR processes. And then another one is on intelligent reconstruction. Those are the steps that we use in AI in MR. So I'll start with the first one. The newer technology that we have on workflow is the AirTouch technology. This is the same as touch and go technology. If you have ever positioned a patient in an MR, the process involved after screening the patient, you position on the couch, you turn on the laser light, you center on the region of interest, you press, you zero that region, and then advance the patient into the center, isocenter of the magnet. Those are multiple processes that are involved. But with the AirTouch technology, there is a sensor that is embedded along the side of the MR couch. So after positioning the patient, you just touch at the side of the couch, and then it will automatically center the patient into the bore. So it's just like touch and go, and there are no multiple processes. So this will improve the setup process by more than half, and also reduce the time at the couch positioning the patient by 37%. So it's quite a significant time, and MR time is very important. The next, after positioning the patient, you now go to the workstation, and there are multiple parameters you have to select from the menu. You open the menu, you select slice thickness, you select all those parameters. This takes time, but we have another technology called auto protocol optimization, which automatically optimizes the protocol for you. So what you have to do after using the AirTouch technology, you touch at the region whereby you want to center, the table automatically advances, you come to the console, you use the automatical protocol optimization, you just turn it on and select the parameters that you want to optimize. So it helps us to scan the patient faster. After that is planning. Once you have optimized your protocol, the next step is to do planning. And as you know that in MR technologies, there are normally some little variation in planning from one technology to the other, even if we follow similar plans. But we have this intelligent slice placement technique, known as the AirX technology, which uses a deep learning algorithm to automatically prescribe the slices. So you just select the region that you want to use. If you want to use the ACPC line, it will automatically, even if the patient changes their position from this video, you can see if the patient changes the head position, they tilt forward or they tilt backwards, the slice orientation automatically corrects for that. And this helps us to plan faster for the exam. And also there are fewer mouse clicks, so you don't have to tilt on this side, tilt on the other side on the coronal and sagittals. But with the X technology, it automatically plans for you the slices. The next is a big advancement in AI in MR, known as the Air Recon DL. This is a deep learning algorithm. So first of all, I'll take you back to what MR is involved, and they are normally a triad of SNR, resolution, and time, whereby if you optimize one, you lose the other one. So if you try to increase on resolution, what do? You reduce the matrix sizes, you reduce the slice gap, you reduce on the slice thickness. But what will happen on the SNR? The SNR will drop. If you want to increase on time, you increase on slice thickness, you try to increase on acceleration, but what will happen with the resolution? The resolution will drop. So there are multiple ways that we have been trying to work around this. By the first one, we said on the increasing on the field strength, going to a higher strength. The other one is increasing on the gradient power. Another one is increasing on the coil elements, using image filters. So image filter will apply on the image that has been processed. So once the image is out, you apply a filter, but this makes the image a bit unrealistic because you're using filters. And also we can use compressed sensing. So the goal for this is to acquire more, improve SNR, and shorten scan time with less sampling. So this is just a short video of that triad. So you see, if you try to optimize on the other, you lose on the other. You cannot have everything at once. Why am I mentioning this? This is because now with the Air Recon deep learning technology, we can be able to achieve a higher SNR, get sharper images, clearer and accurate images without sacrificing on the scan time. So Air Recon DL will work on optimizing on the raw data, not on the processed image. And this is just a scan of the phantom. In conventional imaging, you can see on the small dots. If you try to zoom it out, there will be a lot of ringing or Gibbs artifacts. Gibbs artifacts basically occurs when there is undersampling. And also we lose on the fine details on the smaller dots. But when we use the Air Recon deep learning, it is able to remove on the ringing artifacts and also improve on the details of the structures that we are assessing. So our image becomes sharper, and also we don't see the ringing artifacts because the Air Recon works on the raw data to remove on the artifacts. A real life example is like this image for knee. The last image here is acceptable image. It has a good resolution. But if you notice that we are scanning at 3 minutes 24 seconds using next or number of excitation to 2. If you want to scan faster, what would you do? Let's say you want to decrease the scan time. Using the next or any other parameter. Any. Yes, right now we are scanning. The image is acceptable, but it's at 3 minutes and 24 seconds. And you know we are scanning multiple planes, multiple contrasts, so the cumulative time will be very long. Gap. Any comment? But remember, we have to maintain the same resolution. Scan faster, but not to lose the resolution. If we increase on the slice thickness, we will get better SNR, but our resolution will be lower. If we decrease on the matrix size, our SNR will be higher, but our resolution will be lower. What other parameter can you work around? Without losing on the image quality. From the field of view, if we reduce, that means we'll be cutting some region. So the easiest way that can be done is to reduce on the next from 2 to 1, but what will happen on the image resolution, it will be lower. And our image will be more grainier. Yes, we are able to cut the time by half. With 1next, we are scanning at 1 minute 56 seconds. So next is basically like painting. So like a painter, you are painting an art. So if you paint it once, that is 1next. If you paint it twice, the same place, that is 2next. You can scan multiple next. So what does next does to time? If you double next, it doubles the time. But what does it do to the SNR? Does it double the SNR or no? Yes. There is no wrong answer. By what factor? Yes, it increases. From the first example, I said, if we double next, we double the time. How about the signal? Do we double also? Yeah, so the signal will only increase by the square root of 2, but at the cost of twice the time. So that means the signal will square root of 2 is around 1.48. Increasing by a factor of 1 point, yeah, the square root of 2. Yes. But, so the first step where the image quality was acceptable, good SNR, but the scan time was high. So with an X of 2. So we reduced the next to 1. Our scan time was halved to 1 minute 56 seconds, which is a good time. But our image quality became poor. It's more grainier. But if we scan the same with 1X and using Air-Recon DL, we get a better image, which is almost similar to double the next. So that means we can be able to scan faster with the same scan time. From the previous explanation is that the Air-Recon DL will work on the raw data to remove on the noise, and you only remain with the signal that is better to be used to post-process the image. So the first and the last image are almost the same, but we are scanning at half the time using the AI technology. Are we all clear up to there? Any question, comment before I proceed? Silence may mean we are all understanding. Okay, so the next advancement involves a synthetic MR imaging. I use the example of killing 2 or 3 birds using one stone. So these are technique that is able to generate multiple image contrast using only one acquisition. This technique utilizes a multi-delay, multi-echo, fast-spin echo technique. And the signal that we receive will be dependent on the T1, on the T2, on the proton density, and on the RF of the MR system. In GE Healthcare, one of the synthetic imaging technique is MAGIC, not the black magic, but this means magnetic resonance imaging compilation, the abbreviation. And using this technique, we can be able to generate these multiple outputs, T1, T2, PD, flare, and double inversion recovery, star, phase sensitive inversion recovery. And not only these image contrasts, but also we can be able to generate maps, parametric maps, using only one acquisition with a scan time of around 5 minutes. And you can also be able to manipulate the image contrast to get from the console or the workstation. The workstation for G is known as AW, Advantage Workstation. So from these, this is just an example using the first images are from a MAGIC. So this was only one acquisition. You're able to generate 6 scans. Conventionally, we can scan 6 different times. As you know, MR, you cannot generate different contrasts. You have to acquire that. But with the synthetic technology, you can be able to now generate multiple contrasts only using one acquisition. And that will help us also on the scanning faster. And also producing images of good diagnostic quality, because that's also very important. Another technology is on motion correction. Motion is also a challenge in MR. So we have 2 technologies now in motion correction for 2-dimensional imaging and for 3-dimensional imaging. So for 2-dimensional imaging, we use a propeller. So these techniques will use the radial K-space filling technique. So the lines are filled in blade form. So this helps us to oversample at the center and therefore to compensate on the movement. But this movement is for the patient that is moving in plane, not the patient moving in and out of the bore. That propeller will not be able to compensate for that. But only the patient, let's say they are rotating their head in plane, but not outside the plane. And it's also compatible to Airy Condial, which I mentioned, which will help in improving also the SNR and reduce on the Gibbs artifacts. So with these, we can be able to scan patients without sedation, reduce scan times, reduce artifacts. Yeah. For 3-dimensional imaging, we use a PROMO, which is known as prospective motion correction. These are for 3D imaging technique. And it's also compatible 3D. So they help us to scan also the patients without sedating and also children. And it's compatible with the Airy Condial. So from this image, you can see the patient is moving and you can see a lot of motion artifacts. But with PROMO, same patient, we repeat the scan, it compensates for the motions. Any question? Are we together? Okay, perfect. Another is on bone imaging. Bone imaging, as I said earlier, was reserved for ionizing radiation mainly. So CT, X-ray, but now we can use zero TE imaging techniques. TE is time to echo, the time that you wait before you receive the signal after transmitting. Because of the very short T1 relaxation of bone, we are not able to get signal from bone routinely. But with the zero TE technique, that means there is no TE. We can be able to get signal from bone. And this also uses a radial acquisition. And from the propeller, it may also help in motion compensation. And we can be able to post-process and do volume elimination of the structures. Sorry. As you can see from this skull, was it looks like it was from CT scan, but this was acquired in an MR. So we can be able to assess on the bone morphology, and also it complements when the patient is being scanned for MR and you want to check on a fracture. There's no need to remove the patient and take it to the CT scan. You can just add one additional bone imaging technique, and you can be able to assess if there is a fracture or not. In a follow-up for pediatric with a bone doing multiple irradiations, use this zero T technique to image the bone. Another one is on vessel wall imaging. So we have this sequence, which is a motion sensitized driven equilibrium, which is used to produce black blood imaging. So in black blood imaging, the vessels or the blood in the vessels is black. When that is also motion sensitized, that means that we can be able to see the walls of the vessels very clearly. And this will really help us in assessing for plaques in the vessels. And it can help us also to distinguish from fat containing plaques and other types of plaques. And then lastly is on non-contrast perfusion. This is known as arterial speed labeling. So how does it work? An inversion pulse is transmitted to the base of the skull of the patient, which is a preparatory pulse. And then when the blood flows to the brain, we can be able to quantify the amount of blood that has flown into the brain of the patient. From this ASL technique, we can be able to get cerebral blood flow, CBF, which is the flow of blood into the brain. And as you know, this is a needle-free, so that means we are not using contrast. It's also quantitative, so you can be able to measure the CBF and quantify it, which will help us in follow-up. And also we can be able to adjust on the labeling delay because of variation in pediatrics and elderly patients. That is the end of my presentation. So in case you have any question, you can just raise your hand and then say, or an additional input. This is not the complete list of the enhancements that are occurring now, but it's just a small list. You can expand from this list. No question? Any part that was not clearly explained, I can repeat. Anyone hearing this for the first time? Okay, that's acceptable, perfect. Yeah, so there's always a first time to hear. Every one of us has heard these things for the first time at some point. Yes. Yes. Everything that I've shared now is being used in practice. Yeah. This is the present. I'm not presenting about the future. Yeah. Thank you very much.
Thank you so much, Dennis. Let's appreciate Dennis for the presentation. Clearly we can see that there's a lot of stuff that we don't know about MRI. Yeah? There's a lot of stuff happening out here. And when I look at some of you here, I know what you do in your clinical areas. Yeah? I can actually point out those who have never seen an MRI or have never stepped in an MRI room or cannot even do a plain MRI brain. But that's a story for another day. But what Dennis has presented just shows us that we have a lot of stuff to go through. We still have a lot to learn. Yeah? And I think we will have to incorporate some of these this way of getting knowledge from the industry to supplement what we get from classes. That will make a lot of difference because probably what we learn in classes sometimes it's very difficult to try and use out here. So when we get people from the industry to try and explain to us what is happening currently, I think it will be better and it makes more sense than what happens in our classwork. So thank you so much, Dennis. We will actually call upon you again. Yeah, we'll organize more of this so that we make sure that our students get out there with enough knowledge about what is happening in the field. Si tunataka kushine huku nje. Yeah, so we are going to do more of this. So thank you so much, Dennis. So our next presenter is Camilla. I'll say a little about Camilla, but she'll say the rest. As she said, she works at the Nairobi Hospital. She is an interventional radiographer. And for those who attended the induction for the first years, we said that Camilla is one among the very few ladies that perform interventional radiography in Kenya. Actually, I only know of Camilla and I also know of Agnes of Aga Khan. Those are the only two ladies that do interventional radiology. And it's a good field. It's a very satisfying part of radiography. And of course, I know she'll encourage you, and especially the ladies around here, to actually strive and join this field. It is a very, it's a very good field, as she's going to explain to you. So Camilla, welcome, and thank you for accepting.
Thank you too for inviting. Am I loud or clear enough? My name is Lihanda Achieng. You can call me Camilla or Cameline. Camilla is easier. Like I said earlier, I work at the Nairobi Hospital in Cath Lab. We have a team of 4 currently, and we run the Cath Lab 24 hours. So I'm going to present about trends in imaging technology in Cath Lab and IR. So IR and Cath Lab, in some hospitals, like in Kenyatta, there's an IR suite, and then there's the Cath Lab. So 2 different rooms. But in most hospitals, the Cath Lab is the same that hosts the cardiac procedures, the vascular procedures, and the IR. So let's start by definition. I shouldn't have gone there yet. Should have asked what IR is. Apart from that, who can tell me what they understand about IR? Anyone? as Dennis said, there's no wrong answer. Everything is a trial. Anyone? Anyone? Okay. So basically, IR is a subspecialty in radiology. Okay. So that's where minimally invasive procedures are done to either diagnose or treat conditions. So cath lab uses X-rays and contrast. I should mention contrast because Ken is here in Sydney. And contrast for diagnosis and treatment. It also, the procedures in cath lab are also minimally invasive. So a cath lab unit is a theater, yes, but we only perform minimally invasive procedures. So before I go to trends, first of all, what is IR, what is cath lab, what is done, what procedures are done in IR or cath lab. So I broke them up into 4. So we have cardiac procedures, we have the IR procedures, there's vascular procedures, and cerebrovascular procedures. So cerebrovascular procedures, quote unquote, neuro procedures, okay? We look at each of them. So if you visit any cath lab, the main procedures that are done are cardiac procedures. These include angiograms, angioplasties. Angioplasties can be either just balloon angioplasties or the whole PCI plus the stenting. We have cardiac pacemaker insertions. We have electrophysiology studies. We also do valve procedures, like recently we have done a couple of TAVI, that's the transcatheter aortic valve replacement. There's FFR, that's the fractional flow reserve. There's ventricular septal defect closure. So most of these they're called VSDs, are congenitals. Babies are born with them, so they are corrected or treated in cath lab. Just to get a better understanding of what I'm talking about, I attached a very short or long video. Msilale, sawa. Can you hear anything? Sorry, sound password. Explain. So basically during the procedure you use, you go through this is a femoral artery. Okay, let me just try. So there you remove the needle, you put a sheath. A sheath is plastic. So at this point the patient's, the area where we are working on has been numbed by local anesthesia. That's the wire, it's advanced all the way to the aortic arc. Then the catheter is introduced on the wire up to our area of interest. The area of interest here being the arteries supplying the heart, the coronary arteries. Then the dye is injected You'll see the picture coming up shortly. There you are. So once the dye is injected, in case there's any lesion or any problem, you're able to see. On this image, there it is. It looks like a narrowed area, like a pipe that imefinywa. So that is what is happening at that point. There's plaque. Plaque is like fat deposits. So the angiography is done. Now we are doing the angioplasty. Now the treatment part. They introduce that's a balloon. So the balloon is introduced up to where the plaque is, and then it's inflated. It's given some 2-3 seconds, sometimes timed or not. Then it's deflated and removed. And then if we decide to continue and stent, a stent is a hollow mesh, a wire, that is supposed to hold the place open, because sometimes it collapses again. So if you put a stent, there's surety of maintaining the vessel open. So the stent has a balloon inside. So once you get there, you again inflate the balloon. The stent is left in place, the balloon is deflated and removed. That's it. So that's exactly what happens in cardiac procedures. Most of the cardiac procedures, or all of them, most doctors use the the femur for access to get to where you want to go. But among the other new innovations is lately many people use the radial access. So the next procedures we do in cath lab is cerebrovascular procedures. You can see this is a very beautiful image. This image was not done in CT or X-ray room. This image was done in the cath lab. This is a 360 image. You can rotate it and you'll be able to see the whole, the anatomy. So basically you do DSAs. Who can tell me what a DSA is? Anyone? Mid-level student. Level student knows.
Digital subtraction and geography.
Is it true? He said something on geography. So DSA is digital subtraction and geography. This is where you only want to see the vessels, the quote-unquote angiogram only. So everything else is, again, subtracted, and you only have the vessels. So in this brain, there are many things in the brain, right? But in this image, you can only see the vessels. Sindio? So apart from DSAs, most DSAs are, again, they are not therapeutic, they're diagnostic. So once you do that, then you're able to see where the problem is. Then we also have coiling and embolization. Okay, I think I've asked many questions. Kadra, do you know what embolization is? Or coiling? She has an idea. So basically, coiling and embolization is the treatment part of the cerebrovascular procedures, right? So you find a problem. If, let's say there's an aneurysm, there's a weak spot for the first years. So you use, again, contrast to locate where you need to go. Once you're there, you can do coiling or embolization. This is basically for aneurysms most of the time. And then we have thrombectomy. Thrombectomy is the mechanical removal of clots, right? So in cath lab, we don't open up to remove the clots. So you can use stent retrievers. There's some things called stent retrievers. You direct them to where the clot is. It captures the clot and pulls it out. And it revascularizes the head, right? And then we have angioplasty and stenting, basically almost the same. So this is an example of a stent. So we've moved to vascular. Cerebrovascular and vascular are almost the same. Cerebrovascular is mainly for the head. Vascular is the rest of the arteries and veins. So for vascular, we also have angiography and angioplasties. Angiography basically, as we've said, is you want to see what's the problem. So you do an angiogram, you take a picture like in CT or X-ray. Then after you know where the problem is, now you try and treat. That's the angioplasty. Like the placing of the stent, as I've shown you, or just balloon angioplasty. Then we also do endovascular aneurysm repair. It's called EVA. So there's EVA and then there's TIVA. Once you start your clinicals, you'll hear about EVA and TIVA. EVA is sorry, TIVA is mainly around the thoracic area, EVA is the rest. So again, the same procedure through the femur, you go up to where you want to go, where the aneurysm is, and then you release the stent graft. The stent graft is left in place, and the patient has been revascularized. In this, for example, in this picture, as you can see, this is around the abdominal aorta, right? So the stent comes all the way down to the iliacs. We also, in vascular procedures, we also do embolization. What is embolization? Embolization basically is when you want to block or an artery or a vein that is either abnormal or bleeding or just anything is happening. So most of the time, you do the embolization. Then thrombectomy and thrombolysis, I've explained that. So these vascular procedures can be performed by our radiologist, the interventional radiologist, or by the cardiovascular surgeons. So it's a multidisciplinary for these procedures. So this is an example of a stent we placed recently. It's almost the same as as the other image you've seen, but this is a live one. If you come to my department, I'll gladly show you. Okay. Now to ours, right? So interventional radiology procedures, there are many, but I have chosen just a few. Again, angiogram and angioplasties. As we've seen, angiogram and angioplasties are done by all disciplines, by the cardiac people, by the neuro, by the radiologists, right? By us, when we do CTs and fluoroscopy procedures, still angiograms. They do biopsies. So biopsies are either CT-guided biopsies, ultrasound-guided biopsies, or biopsies can also be done in the cath lab. Then we have FNAs, the fine needle aspirations. Most FNAs or all FNAs are ultrasound-guided. Then there's bleeding control. So you've heard about postpartum hemorrhage. So a woman gives birth. Right after birth, the patient is bleeding profusely. So our IRs are called in. The IR team is called in. Using cath lab IR procedures, quote unquote, to sort the bleeding and stop it. How do we stop the bleeding? Again, embolization, right? So other embolization procedures include uterine artery embolizations. You've heard of people who've gone for surgery to remove fibroids, right? So currently, if you hear anyone who wants to do surgery, open surgery, you talk them into doing a UAE. A UAE. Why? A UAE is safe, it's short stay, it's less costly. So the patient walks into the unit in the morning, by evening they go back home. How is a UAE done? Same procedure, you go in through the femur or the arm to the uterine artery, you put in the blocking agents, embospheres, there are a couple of them. It blocks, I like saying this, you starve the fibroid. How do you stop the fibroid? The artery has been blocked. Artery is the one that feeds the fibroid, right? So when the artery is blocked, it dies, it shrinks. When this patient comes back for an MRI a couple of months later, there will be significant reduce in the size of the fibroid. So it doesn't happen like in a week or two, it takes time, because again, the fibroid was already had. Ilikuwa imenona, si ndio? Yeah. Then we also have prostate artery embolization. Most of the time is for BPH, benign prostate hypertrophy. It's the same procedure. You embolize the artery that's supplying blood, right, to the prostate. Then in interventional radiology, we also have AVM repair. What's an AVM? An AVM is an arteriovenous malformation. The artery and the venous somewhere are joining. So blood rich in O2 is mixing with deoxygenated blood, right? Any question up to there? At least now you know what IR is. Ndio? Thank you. There's, now, I'll leave this for later. So we also have IVC placement. An IVC filter is placed around the same area where you saw in this picture. So IVC filter is placed around the same area, just above the iliacs. Why do we put an IVC filter? An IVC filter looks like an umbrella. It looks like that. it blocks, not really blocks, it stays in place. In case of any blood clots trying to run or go up the vessel, it stops them there. Most of the patients who get IVC filters also have are on medication to dissolve the clots. Someone was going to ask me what the clots will block. No, they won't block, right? So IVC filter placement. There's laser therapy, like when you want to treat varicose veins, you use laser therapy, still done by radiologists and radiographers. Then again, thrombolysis and thrombectomy is happening. You can see it everywhere. We have percutaneous nephrostomy. What's percutaneous nephrostomy? The patient is not able to pass urine from the kidney all the way down. What do? You introduce a catheter right through the skin into the kidney. You've seen patients walk around with catheters hanging from their sides, so that's it. It's I like calling it a temporary solution because these patients later come in for stenting. What is stenting? You put something that is from the kidney to the bladder, helps with draining of the urine. It's okay. There it is: biliary drainage and stenting. Then also we do dialysis access. Let's go back to chemoembolization. What is chemoembolization? Chemoembolization is when you use embolic agents mixed with the... oh, someone wanted to answer. Yes. She wants to try. Where's the microphone? You can use mine.
Possibly they're using some kind of chemicals. Okay, from the word itself, chemoembolization, the chemo part, I think they use or they employ use of some chemicals or pharmaceuticals, something like that.
Good, she tried. Actually, she got it correctly. So remember, when doing embolizations, let's say for the benign ones like the fibroids, you use only the embolic agents. Embolic agents, again, it's the things you use to block the arteries. You can use gel. There's something called gel form. There's one that is in liquid. You can do coiling. There are a couple of them, right? So here you use an embolic agent that is mixed with nadawa, ile dawa ya kimo yenyewe. So this is good. Why? It targets the tumor itself, right? It goes directly to where the tumor, you go directly to where the tumor is and you deliver the embolic agents. I hope this time we'll get some volume. Devi, I have another video about TESS. TESS is the latest. I like it. Why? Because this patient doesn't have to go through all the, you know how cancer patients are in Kenya are suffering, right? So I like TESS. It really helps the patient, right? Okay. Basically, this is how cath lab looks. This is a single plane cath lab. For those who've never been to a cath lab, that's how it looks. I'm going to talk about later on. I'll talk about the use of multimodality among the innovations. You can see this is one. So we're using ultrasound for access in the cath lab. So we have both the cath lab, the C-arm, and ultrasound for this procedure. So it's the same. You're going through the femoral artery. You remove the needle. The wire remains inside. The wire is very small. Then you put the sheath. This is the only point or part where the patient feels anything, just a little bit of pressure, right? Again, you put the wire, you go to your area of interest. Then you put that's the sheath. The sheath is plastic, so it can go with the contour of the vessel. I've already had a question. Someone's going to ask. So that's normal saline infusion. The catheter is being advanced. So the catheter normally goes all the way up and then comes down. It's interesting, right? I work in an interesting department. Ndio. How many are coming to Cath Lab? Yay! Niko na wafuasi. Very interesting. You actually can't get bored. So once you go up, it curves, then you come back. Now you're able to get to where you want to go. So that's your tumor, right? You can see where the catheter has gone, up to right next kwa mlango ya hiyo tumor. Like, I'm going to starve you. Hautoki hapa leo, hautakula. Sindio? So it's right there. Then the embolic agents are introduced. So procedure is the same. So we have TACE, we have TAE. What is DEB? DEB is the drug eluting. So, okay, let it play. I'll talk about drug eluting somewhere in front. But now you have an idea of how this is done, right? Thank you. So now let's go to the emerging trends. From my presentation, how many trends have you seen? How many? You can use the microphone. Wapatie huko nyuma pia niliona ukiandika. So far, how many have you seen?
I'm not sure.
Yes.
But as an emerging trend, I would consider embolization procedures.
Embolization itself, right?
Yes.
So back then we would run to you have a bleed in the head, we would run to the theater, open up, try and get where the bleeding is, sort it out, go to ICU for a couple of weeks or months. Thank you, that's correct. Another one? Any other that?
I think from the last video that you played, an emerging trend is TACE.
Thank you.
Yeah.
So the patient would have gone for chemo, right? Ken was trying to explain something earlier about you don't want the contrast to go to a different place, but it goes. Why? Because it's in the blood, right? So like TACE, it's targeted therapy. It targets the tumor only. It doesn't try to treat even the good cells, right? Any other? Mlikuwa mnasikia? This side, they're on the microphone, that side. CC, thank you for listening.
We have nephrostomy.
Nephrostomy?
Nephrostomy.
Thank you, Kadra. So who remembers what nephrostomy is? Yes. Just a minute. This one remembers what nephrostomy is.
But from what I understood, it's use of a catheter that is directed to the kidney. Then we have a urine collection bag that a person can exist with.
Thank you. How is that good or new or an innovation? Previously, would the patient get that? No, but now you just come. It's actually a very short procedure, 10-15 minutes you're out. Urine is draining as you wait for that. Maybe a kidney replacement or something else. Yes?
I think that chemoembolization, that aspect of additional use of chemicals that during embolization?
Thank you. So it has done two procedures in one: the embolization and administering of chemo drugs. India. Thumbs up. So where does it fall? Where does it fall? So that was in the those are the many innovations and trends that are in IR that are again a plus to the patient, right? So in addition, we have intravascular ultrasonography. It's called IVUS. So what does IVUS do? IVUS is a special kind of ultrasound. It takes ultrasounds inside the vessel. Why is it good or important? Back then, maybe we would do the stenting, would gaze and be like, how big will this stent be? How small, right? But right now, when you have IVUS, you're able to do the correct measurements. You're able to plan your angioplasty as well, right? So it helps you to assess the plaque. It helps you to evaluate the plaque composition. The plaque is basically the whatever is blocking the artery. It helps you to characterize the vessel, right? So that you're able to, again, be able to make a decision: which balloons are we going to use, which stents are we going to use, which size, right? Even still in IVUS, IVUS itself has also been innovated into a better. So the images right now are much better than the ones that were there before. So it is also something that is evolving, right? Then let me move to the next one. There's the 3D rotational angiography. What is 3D? 3D-RA. So it has three parts. First of all is when you take the image, the normal image. Once you've taken the normal image, it is reconstructed into a 3D rotational image. The doctor is able to assess the let's say an aneurysm. This is best used in neuro, even in vascular procedures. You're able to assess, you're able to plan how to treat the aneurysm or whatever lesion you found. Then we move to fusion imaging. Fusion imaging is when you incorporate different other, right? We have machines right now where you do a CT scan, the CT scan comes directly into cath lab. We assess the images from CT or from our echo. Currently in Nairobi Hospital, we have a new echo machine that does this. They can send the images into the cath lab, and as you're doing your SVD treatment for the baby, you can be able to look at the scans that were done earlier. Then we have fluoroscopy innovations. This is very close to my heart. Why? Fluoroscopy is basically radiation, right? Who likes radiation? Who wants too much radiation? Why are people scared of working in cath lab? Because of radiation. So we have currently machines that have low dose fluoroscopy. You're able to reduce your dose to minimal, and yet the image that you're doing is still good. There is positioning without radiation. So you take a very short fluoro image. The doctor stops, or you stop radiating. You move the patient or the table to your area of interest without radiation, right? This is a plus because it helps with patient safety and the staff safety. Less radiation to the patient, less radiation to us, right? Then we also something called, sorry, that's a typo. There's something called fluorosieve. So back then you would fluoro. After you fluoro, you get to where you want to go. You take a picture. It's called a cine image, which is also takes a little bit more radiation. But right now, with as you're doing your scans, you can save the fluoros. Fluoros uses a little less radiation than cines. So you save your fluoros as you go. Saves on radiation. Then we have simulation imaging. Simulation imaging is basically where, simulation training is basically where me and you, or the radiologist, cardiologist, or cardiovascular surgeon is trained on a, should I call it a dummy? You train before you attend to the patient. You've done several of them on a dummy, quote unquote. By the time you're coming to do a test, you've perfected your art, right? Again, reduces death, trial and error, blah, blah, blah. Good for the patient, good for me, right? Then we have more. We have DEB and DES. Basically, this is a drug-eluting balloon or a drug-eluting stent. Why is this good? So you have put a balloon in, it's left in for a couple of minutes, sorry, a minute or a minute and a half. The drug is taken up by the vessel. In the stent is the same. So once the stent is in, it keeps eluting the dawa to the vessel, right? So it treats even after the procedure. In simple English, it treats even after the procedure, right? Then we have MRI compatible stents and devices. I'm sure those of you who've been to MRI, you've heard when a patient is asked, do you have a pacemaker? Do you have? So currently we have stents, we have pacemakers that are MRI compatible. The patient can safely do an MRI when they have these stents and pacemakers, for example. Then there's AI image analysis. Again, AI. Everyone runs away from AI, but AI is here, right? We also have biplane machines. So the video that was playing, you've seen one C-arm, like a C, right? So now currently we have machines that have 2 of those C-arms. So you have one C-arm. Here. The other C-arm is here. So I'm able to take images, for example, of the spine. I can do an APN lateral in one shoot, right? I don't need to, it doesn't take time for me to again turn the machine, do a lateral, come back, do this one. It saves time, right? These machines make work so easy and so efficient. Then we have the oncology innovations, again, close to my heart. Why? Because you know what cancer patients go through, right? So we've discussed a couple of them. There's the TACE, right? Why do we like this? There's ablation, there's TACE. Why is this good? Because it offers targeted therapy. It targets only the sick cells, right? Then we have image navigation. So let's go back to my previous video. You have taken an image, right? Where was it? So you have done the diagnostic part. The diagnostic part is when you take images. Was it here? No, it was the cardiac one. So you do the diagnostic part. Now we need to treat, right? And for treatment, most of the times you change catheters. You want to get to the smallest part, right? We need to get to where our stenosis was. Let's get our stenosis. There we are. So we need to get there, right where the stenosis is, right? So image navigation, you're able to superimpose this image that you took earlier with fluoro. It helps the doctor just smoothly, very easily navigate to there. You don't need to keep giving contrast. Take a picture as you monitor progress. Take a picture, contrast. Picture, contrast. See? For our kidney patients, this is a plus. Why? Less kidney. For all of us, this is a plus. Why? Less radiation. Trying to navigate to get to where we want to go. Right? So we have image navigation techniques that are now in most machines. They help the doctor to get to where they want to go without overexposing the patient. Even in the tiniest, even in the head. Let's say we have 3D array, you put it together with the image navigation, right? The doctor is able to go to the tiniest vessel without struggling. Sawa sawa. Any questions up to there? Am I too fast? Am I too slow? Okay, tumeongea sana. Why are we happy about all these innovations? We've said them 3-4 times. Why are we happy about them? Again, audience. Kenneth, why are we happy about the doctor being able to get to that small vessel without struggling? 1. Minimizes procedure time. She's loud. Tumekusikia.
It minimizes the procedure time and reduces the risk to the patient.
Thank you.
As risks would be posed if there was an open surgery.
Thank you. Let's take an example of which one is the easiest? The cardiac. So the patient needs to go for an open heart surgery. Why? Because you want to go and repair a blocked artery. How long will that take? How much will that cost? Right? It's again, as she says, it minimizes risk. Open heart surgery, you've opened how many layers of skin, of tissue, of everything have you gone through to get to the heart? 2. Let's say the one for you have an aneurysm in the head, right? How long will it take you to prepare to go to theater, open up your head and do all that, right? Next person. Thank you. She's covered 2, patient safety and recovery time. I've told you lately we're trying to move from the femur to the arm. You can actually walk out of cath lab and go home after that procedure, right? Or an hour after the procedure. Why? Because there's nothing much. We are not treating, it's not a big wound, a big open heart wound that we need to sort. Or part of your scalp was opened. So less recovery time and patient safety.
Simply, it's less invasive compared to the conventional procedures.
Thank you. It's minimally invasive. IR and cath lab procedures are all of them minimally invasive procedures. Unless something happens, then we will need to open up the patient. Another thing is, give an example of a TAVI. What is a TAVI? I mentioned the TAVI. Thank you. When you're sorting the valve out, right? Most of the TAVI patients don't have a go-ahead for the heart procedure because they have many other things that are happening in their bodies. So because of these other many other things, we can't sort your valve. Your valve, weka tu nayo hivyo, right? And then comes IR and cath lab, like we kuja, come, we will sort you out. So patient outcomes are better. There's a hand somewhere here. I answered her. So again, less hospital stay, faster recovery times, accurate diagnosis. Imagine if you have a 3D image of those small vessels in the head. You can zoom it out, you can turn it around, you can play around with it. It's very enjoyable. You guys should come and work in cath lab, please. Wachana na Dennis na MRI. Sawa. Hebu ngoja kwanza, Sydney is my senior. I forgot to mention. Sydney is my senior, former IR. Say anashika pesa.
No. So it's also very less painful. Yeah. You may do all this and the patient is discharged the same day. Rather maybe going the process of ICU, HDU, ward before your discharge. Less painful. Less low risk of infection or vivid, so things are done well. As the wound is healing, all that.
Thank you, Sydney. So, when you see all these things, don't you feel like it feels nice to work in cath lab? One, isn't it nice to be a patient in cath lab? Right? When the patient walks out, imagine you're in theater, you've opened up the heart or the head. Do you think this patient can come out and smile at you and say, thank you, Camilla? No. Ours is more rewarding. Sorry, watu wengine. That's the end of my presentation. I forgot to ask any questions. Yes, Kadra.
So how do you deal with radiation safety while conducting interventional radiography procedures?
Thank you. I like that question. The cath lab unit does not only have the shields that we wear in X-ray. We have ceiling suspended shields. We have mobile shields. We have bedside shields. There's also the factor of distance. So those people close to the C-arm One, I put him on the lead gown, the thyroid shield, the glasses, right? The ceiling suspended shield is hanging right next to the C-arm. You have the mobile shield down here to protect from any strays, and you also have the bedside shields. The current machines have put in a lot of effort on radiation safety. That's one. Apart from the shields is the fluoro. Again, fluoro is less radiation than Cine. FluoroSave helps reduce the level of radiation to both me and the patient. Apart from FluoroSave, the navigation, most navigations, it's use low dose. It's called low dose radiation, right? I think I answered.
I have another question. So, approximately in next 6 months time, how many of radiation dose does your body normally take through all the procedures?
Okay, I don't know if there's any research that has been done, but all the cath lab personnel, we have the radiation monitoring devices, the TLDs that are measured monthly. So I can check and get back to you, but none of us has ever surpassed or gone past the required. None of us has been sent home. By the way, if you overdo radiation, you're sent home. Sikufutwa kazi, sindio? Wendo pumzike. Right? Ken, am I correct? My seniors. Miss Jafika hapo. Yes.
Maybe before Halima, radiation safety has really been taken care of, and as radiographers, we shouldn't be worried about this. Remember, the maximum permissible dose for radiation workers is 20 millisieverts per year. We rarely get into that. Yeah, that is about 1.6 millisieverts per month. And even those people working in cath lab, and even the normal fluoroscopy that we used to do that is currently not very common, we rarely surpass that, because a lot of interest has been put into radiation protection. So as Camila is saying, there are shields. If you over fluoro, it will give you a warning that you've actually you're going beyond, and it will actually stop screening until you reset again. So radiation safety should not be a big worry. And if you get anything above the recommended level, probably the machine has a problem. And that is why we do what we call radiation assessment every year for the equipment, just to make sure that the radiation that is coming out of the equipment is actually within the acceptable levels. So radiation protection, unless you as a staff is careless, the equipment itself, the way it's been made, has taken care of radiation safety. Thank you.
Maybe also, Camila, maybe you remember some of the things are coming out of my way. So that the radiation we use when we are doing intervention, just like the way we are doing in II in theater, these are screening mode. I may not fully remember how we used to call it. Is a screening mode, not an exposing mode where you screen, but if you want to expose now, you can do the real exposure.
I think currently we call it low dose fluoro. It's, you don't need to check the picture itself. You don't need to Cine the Cine, because the Cine has more radiation than the fluoro. So you can just take a short fluoro and then you use it as you would have used the Cine image. Thank you, Sydney.
Question. Thank you for the presentation.
Thank you.
My question is on a patient with varicose vein with thrombophlebitis. What are the best management for that patient?
The best
management.
Management.
Yes.
So I always hear, or I know that with an infection, you treat the infection first before you try and remove the clot, right? So again, treat the infection first, then come and do thrombolysis or thrombectomy. depending on how the patient responds to that treatment. You answered? Varicose veins is treated by laser. Yeah, currently we use laser to treat varicose veins. Laser ablation. Yeah. Minimally invasive. Any other question before I... Susan, give him type. Ken wants to present.
I'm guys saying, okay, one question from me. That's a career path. Do you join the IR team post-graduation, or do you have to take another certification before you can work in the cath lab?
There's post certification. Most of the time you do short courses. Currently there is no certification in Kenya, if I'm not wrong, like KMTC or JKUAT, Mr. Maura. For basically only IR, no. So you have to do the whole radiography. Then once you're out there, you can do short courses. They're offered online. We have it in India. We have it in Egypt, South Africa. I think offers, yeah. Or in-house training. You start with in-house training. Once you know, then you go and look for the certificate. It's easier that way, right? I've answered 2 questions in one. Thank you, guys. Thank you for listening. For the people online, thank you. Again, my name is Camilla, the Nairobi Hospital Cath Lab.
Thank you, Camilla. You know, some of us think that radiography is very boring. Camilla has just shown us how interesting radiography can be. But you need to, tunasema kujituma. Yeah, for you to do cath lab and do these interesting things that we talk about, you have to jituma. Bila hiyo, nobody will actually tell you to go and do cath labs. We will just train you to be a radiographer, and from there, you decide which path you want to pursue. And that becomes your responsibility. Nobody will tell you what to do. In our present setup, we do not, because of not many hospitals have cath labs, okay? And we do not really allocate students to cath labs, if you've noted. But that doesn't mean that you can't go to a place where there's a cath lab and then request to go and see what happens there. So guys, kujituma. Ukienda Nairobi Hospital, usiende tu ukwame X-ray, ukwame CT, ukwame MRI. You can also go to cath lab and learn what they do there. Yeah, you just do something extra, and that is what makes a difference in your life. So thank you so much, Camilla. A round of applause for Camilla. Thank you. Now our next presenter is a very important presenter. Without him or without the group, will not be here. Okay? We really appreciate their support. They've been very supportive in many of the Kursa activities, and we really appreciate. So Ken is going to talk to us. Ken is going to talk to us, make a presentation, and of course it's a presentation about the products that they have. And at this juncture, I think it's very important for us to realize that we also need to be good ambassadors of GE out there. Even as they show us the products that they have, we also need to go out there and talk about the products that they have and the good part of the product. Remember, by the way, GE, their products are actually world class, standard. Yeah? You can rarely compare their products with other products. I'm saying this because I've had the privilege of using different products from GE. Be they equipment, be they contrast, you can't beat GE. And I think we are really proud to be associated with GE. So without wasting much time, I'll welcome Ken to make his presentation. Karibu.
Where are the IT experts? Is it visible on Zoom? For those who are in Zoom? I think I saw Kandra on Zoom. It's not. What about now in Zoom? Don't worry, mine will be 10 minutes. So Okay. I think we can proceed. So let me see where it's supposed to begin. Okay. All right. So because of time, I will just. I think the WhatsApp, what do you call him? The Zoom cannot hear us, but I think it's fine with the arrangement that you already have put in place. So my name is Kenneth Kariuki, healthcare, pharmaceutical diagnostics. So in G Healthcare, we have two business units. One is the healthcare devices, what we call healthcare systems, where we have what Dennis has presented, plus very many other modalities, CT, cath lab devices, as our sister has presented. We also have theater and ICU equipment and devices, and then we have pharmaceutical diagnostics. So that's the business that I look after in East Africa for G Healthcare. So in pharmaceutical diagnostics is purely a pharmaceutical company because of contrast media and nuclear medicine consumables. So as we are purely pharmaceutical company within a devices setting. So I will not really speak about the product, but in line with what has been presented in terms of what Dennis said about innovations, and in line of what Kandra and Camilla have also presented, I will just share what as GE we are doing in the space of MRI. And as you can see from that first slide, we are talking about expanding your options from G Healthcare. So we're going to see how this is happening. And as you can see here, there's a molecule that we have recently launched in Kenya. And for the sake of YouTube, I just want to put a disclaimer that this presentation is for healthcare professionals. So in case anyone in YouTube is not an healthcare professional, just know the content is for healthcare professionals, And also secondly, as a pharmaceutical company, we are highly regulated, and it's worth to mention that for those who are outside Kenya, because Clariscan is registered in Kenya by Pharmacy and Poison Board, and also in Ethiopia and Tanzania from my markets in East Africa. So anyone outside those countries need to consult their regulators with regards to Clariscan. But for Kenya, Ethiopia, and Tanzania, I think we are fine because the product is registered there. So we are bringing this new addition plus the G Healthcare expertise, and you have had David mention that he has used and interacted with us for many years. I remember when Getao, you were in Aga Khan, I think your first your first CT scan was a GE CT scan, the very first in Aga Khan, Nairobi. And I'm not sure whether you were there or some people before you, but the first one, it was a GE. But what is good is that after 15 years, they kept buying other equipments, and they would break down and they would rush to the G equipment. So they were saying that is the workhorse, So they had other equipments for other reasons. They would buy after that one, and then in case they break down, they would rush to the G equipment. So that's the versatility that we bring with our devices. Adding possibilities, as you can see, this is what Dennis was saying about innovation. You can see from 1973, we are talking about MR, and you can see how we have evolved, and pioneering things and discovering things, and being the first in many ways. Because as a healthcare company, we are driven by what we call precision healthcare. And a big chunk of investment is towards this purpose. For example, we listen to you once you go to the field and you become radiographers, professionals. We listen to you and see where you're getting the challenges. In every modality that we operate in, we listen. And our teams that go to see customers, they have a task of listening to the challenges that you are going through and cascading it upwards. And we have people who stay somewhere in the back door to just try and solve those challenges. Okay? So there's a team of people, of course, very highly educated as well, because they are scientists, who stay behind bars there and ensure that they are solving the problems that are emanating from the feedbacks that you bring. You will see even an equipment like ultrasound, for example, you will see changes coming each and every time. Because, for example, an equipment will come that is not ergonomic, for example, and then next time you'll find a device that is more ergonomic. You see all these kind of designs, especially in ultrasound, even CT, in MR. They emanate from the feedback that you give, okay? Sorry, this is not a PowerPoint, so you bear with it. We can still discuss. For MRI, not CT, for MRI contrast, for MR. That's very good for CT, yes, you're right. What about for MRI? Madam Chair, you presented very good slides on MR. What is the basis of MRI contrast? What is the classification, rather?
Pardon?
Okay, let me just say. So for MRI, you can see one here. You can see macrocyclic. So MRI is about the structure of how the gadolinium is protected. Okay, the molecule, the gadolinium molecule. So you have macrocyclics and you have linear structure. Okay. So for linear, I'm not talking about it because these have been there for long with G. I'm just talking about this addition, which is a macrocyclic. And as you can see, the gadolinium is extremely protected. You know, it is not free to come out of the molecule and go to the brain. You remember I mentioned about gadolinium brain deposition. So these macrocyclics, they have less of that because the gadolinium molecule is highly protected. And then plus G healthcare, I'm saying this is an addition, and being an addition, it is a molecule that has been in existence before. So we have just developed it as G, and we are putting in our expertise so that we can achieve all these 4 qualities here. Very important. I think the lighting is not allowing the screen to be visible, but I can read. So it is a cage-like structure, as I've said, enclosing and tightly binding the gadolinium ion. And then you require it to be highly stable once it's called in vitro, inside the body. Yeah, and biologically inert, plus rapid biodistribution and elimination. So what we are saying here is that the moment you inject these molecules, either in CT or in MRI, the contrast media, you remember they are not supposed to be biologically active. You know, they are not having any pharmaceutical or therapeutic purpose inside the body, right? It's just to give you the enhancement and you eliminate it, all right? So you need one that is easily biodistributed, such that it can go to the required organ within the time frame that you want, and also easily eliminated through the kidneys. And then we are talking about adding inclusivity. So inclusivity, we simply mean, of course, there's this discussion, Dennis, and I think as an expert in MRI, you will try to advise me and Sydney. When we interact with the radiologists and MRI radiographers, they keep asking us about contrast media for MR, for specific organs. You need to assist us to see how to deal with that, because for GE, we have one molecule that is for whole body. You know, as you can see here, whole body MR, including major organs. So you see people telling us, do you have one for liver? Do you have one for, I don't know, pancreas? So you need to have a discussion around that with the expert in MRI here, so that we can see where we are fitting as GE, because I believe we have the product that does. Also in CT, for example, our product is only one Omnipec, and it does all indication. Actually, it has the highest number of indications compared to other contrast in CT that are non-ionic or smaller. So same as MRI, you can see it can do musculoskeletal, pelvis, breast, major organs, CNS, including brain, spine, and surrounding tissues, plus MR angiography, right? But most importantly, for Clariscan, you can even do to children below 6 months, yeah, and MR angiography for the same children. So this is an addition to what you have been having. The linears mostly are contraindicated for children below 6 months, but for macrocyclics, this is an indication. You can proceed, including those with hepatic, impaired hepatic function, and also most importantly, impaired renal function. So same as CT, where we have VCPIC, that which is also smaller, and then you're supposed to give it to your patients that are have impaired renal function. In MR, macrocyclics play this. So when you have a macrocyclic molecule, then you are able to attend to all your patients. Of course, with an understanding of the parameters of each and every patient as you are supposed to have. I think I need to move using this. Okay. Yeah, the rest is just speaking about the efficiency that we bring with our packaging. I will not really discuss that. As I said, this molecule, gatoteric acid, is a molecule that has been in existence, but at GE we have developed it ourselves, the same molecule, and that's why I'm saying we are adding confidence, because all the procedures from production of, who knows what is an API? I said we are also in a pharmacology class. What is an API? Someone? It is active pharmaceutical ingredient. Okay. So contrast media, they have this substance called API. It is the active ingredient. For example, for our city contrast, Omnipic, the active ingredient is iohexol, all right? And for this linear contrast, Omniscan, it is gadodiamide, active ingredient. And why this is important is because, for example, if you have gone to various hospitals, especially nowadays, I'm sure you have experienced some iohexol or other Omnipic generics, right? Some other products that have an active ingredient known as iohexol. Have you experienced that? In some hospitals, that is not Omnipic, but it is iohexol. You have? Yeah. So those ones, they are called generics. And the difference in generics and the brands don't necessarily have any difference, but the procedure of preparing that iohexol can sometimes differ from one producer to another. Okay? And what I'm saying is, in very simple terms. So we have seen contrast that is iohexol, and they are saying this is iohexol like Omnipic, and then we're going to give you at a certain price which is cheaper than Omnipic. But when you use it, if you have used Omnipic for a while, you find some differences in efficiency and efficacy, right? Then why is that difference if it is iohexol? Because of, other than iohexol, you are not injecting iohexol 100% substance. It is mixed with very other things, isn't it? For it to become contrast media. It undergoes processes, and that's why we are saying we are keeping all production in-house as GE. From producing this API to developing the contrast itself, everything is in-house. And by in-house, we mean there are procedures that we need to comply with, like GMP. Who knows what is GMP? Again, in pharmacology, it is good manufacturing practice. So good manufacturing practice is a whole dose of SOPs that any manufacturer needs to follow. So sometimes they are standard actually. They are regulated standard-wise. Like for example, in Kenya, they would be administered by Pharmacy and Poison Board. In other jurisdictions, we have FDA. Every country have their own regulators. But the challenge is they are not necessarily followed to the letter. And that's why you find that you have differences between efficacy and efficiency of various products despite them having the same active ingredients. This is good to note because once you get to the field, you might find these challenges where some procurement people, they want to tell you, this one is the same as the one you want. Why do you want to buy the one you want expensively, for example, by 200 bob? Those are discussions you find, but as clinicians and as professionals in the field, you need to know why you're using what you're using. I think we're almost now. So this is what I've spoken about. Gatoteric acid, which was a pre-existing molecule, plus the GE Healthcare commitment to quality. Macrocyclic molecule, plus the expertise and commitment. And then the established heritage with the gatoteric acid and ongoing investment within GE. No, there was number 9. Okay. All right. I think that's the end of my brief talk. I know I'm a friend of everybody because I took 5 minutes instead of 30 like Toduyang, isn't it? Huh? So thank you very much. In case of any questions, please, we can interact now or even afterwards. Thank you, David, for organizing this. I think it is important to propagate these conversations. I mean, we were not privileged to have such discussions when we were like you. So I really feel good when I have an opportunity to interact with the students, because I know in the future, things healthcare will be better than now. Yeah, because you'll have students who are going into the health workforce, who are prepared, who are knowledgeable, you know, who are ready to support the healthcare system. And on the issue of IR, I think last week we had same discussion in Nyeri, World Radiography Day. I think the JQuA team came later. There was a very good presentation with an interventional radiologist based in Nyeri, who did a very good discussion, and he was really passionate to have radiographers learn about this IR. And I think from that meeting, because the management of KMTC was also there, they agreed that they're going to start something like this, IR diploma or something. So please, Camilla, you can stream to KMTC and see how far they are going, because they said they want to start that. At least in Nyeri, they have an intervention radiologist who is passionate and ready for that. So that's a plus. So what they are lacking maybe is a cath lab, but I think they have some CMs or something like this. So it follows, of course, imaging follows the investment, the requisite investment. So I think once that training comes, you can have people who getting into that. Yeah. So thank you very much.
Thank you, Ken. I think we've come to the end of our presentations today. We've learned a lot. We've realized that there's a lot out here that we need to know. So we need to do more of this, and we need to prepare our radiographers so that when they go out to the field there, they know what they are doing, and they are the best in the field when they are out there. So thank you so much, Ken, and all the other presenters. We really appreciate your time and your effort, and we really appreciate as JKURSA. And I've also been informed, or rather I've seen that some of our colleagues have been following the presentations online, and they have actually asked me to pass regards to everybody that has made the presentation. GE, Ken and the group, Dennis, and I've actually been asked to talk about the Nairobi Hospital for allowing Camilla to come and make the presentation. We really appreciate. We are actually, as a department, we appreciate collaboration between the different institutions that actually support the practice of radiography in Kenya. And we are ready to partner with any other group that is willing to lift the standards of radiography in Kenya. And as the only university training bachelors in radiography, we are actually very proud to be associated with these groups. So thank you so much. I've been speaking a lot. What I want to do is to get one of the students to come and give a vote of thanks. Okay? Any volunteer? Any volunteer? Okay, Ruth. And then, of course, after that, she will direct us on what to do next.
All right. Once again, good evening. Our esteemed guests from GE, our presenters, starting from our own MS Kadra, then Mila, everyone who has come. Personally, I really appreciate all of you for finding this time and responding to our impromptu announcement. And we say thank you very much for your attention. We want to appreciate our guest for coming and gracing this occasion and dispensing the knowledge that you have. Today we've learned a lot. Personally, I've learned a lot. I've also seen, just from watching, I know IR is interesting, and I think I'll consider it. Camila, see you soon. Thank you. Then thank you, our MR presenter, Dr. Tudoyang. I guess I've gotten the name right. Pardon me if I've butchered it. Thank you very much for coming, and thank you for your presentation. As students, on behalf of the students, both online and here physical, we appreciate very much for, enlightening us on the new trends. I was wondering, now where are these things? We are just used for the conventional, but I believe as time goes by, we are running into new technology. We will meet them. Cindy? Yes. Our treasure, Mr. Dr. Sydney, Mr. Okay, Mr. Sydney, we appreciate you, though you've not presented, but we acknowledge your presence. Thank you for coming. To our patron, thank you for organizing this session. It's actually a good deal. We've had, I think this is the second hybrid CME we've had with GE in collaboration with our patron. We appreciate him so much. Okay, before I wind up, to the executive team for JKURSA, I appreciate all of you for working in collaboration, working together tirelessly, organizing this. It's not easy, but with your support, both from our patron and even the members as our students, we really appreciate your collaboration and your, cooperation. Yeah. Thank you very much. So in a nutshell, I want us to do a 5 factorial to cover up for everything. And above all, we thank God for giving us this chance. It is by His grace and mercies. So let us warm the tube. Please warm the tube.
As we do that,
Yes.
I would like to appreciate the presence of our senior, Njue, who has been following the presentation online. I would also like to appreciate our staff, Dr. Kahato, for following up on the presentation online. We really appreciate them. Thank you.
Thank you. Sorry for missing on that. We appreciate you both, our online viewers. Thank you. So let's warm the tube. Everyone, can I see you? Prepare. We want to do a 5 factorial. Sawa sawa. Yes. I know you believe, you know what I mean. So in 1, 2, 3, let's go. 1, 2, 3, 1, 2. Thank you very much. May God bless you. So from here, I think we'll have our snack for the physical one. The online guys, you can have, you can do a snack at your place. Okay, thank you very much. So I think the order is we'll start with our guests. They will serve first, then wenyeji tutafuata. Sawa sawa. Thank you very much. And before I wind up, next Friday, kindly relaying my invite to all of you. I know you are aware we have a white coat next Friday. Our guests, please don't miss. We will wish to see you again and again. For the students, you know what is required of you. It's only 500 shillings, and you're welcome. And let's come and grace the occasion. Sawa sawa. May God bless you. Have a nice evening.
Please make sure that you've signed the attendance list before you leave.
Thank you very much.